Welcome to our part 3, which is going to cover lower GI disorders. Part 4 will also be in this coming up later on, but we are going to talk about lower GI stuff right now with irritable bowel syndrome, chronic inflammatory bowel disease. So, irritable bowel syndrome is abdominal pain that occurs and altered bowel habits for which no other cause can be found. So, really, the pathophys behind this is pretty simple, and there's lots of different subtypes of IBS, but it's very broad, and incidence is about between 10 to 15% of Americans. Different types, which is you guys are going to need to know these, and so we have IBS-C, which is a constipation type. We have IBS Part D, which is a diarrhea type. IBS-M is mixed, so sometimes they have constipation and sometimes they go through periods of diarrhea. And then we also have IBS unclassified. And so really important, if you present with a patient like this, you need to determine what type of IBS that they are dealing with if they do have a diagnosis of that, because it definitely is going to affect the treatment for IBS. Possible theories for IBS, though, is going to be GI motility issues, visceral hypersensitivity, so maybe sensitive to certain types of foods or different types of medications, whatever we're putting in the body, inflammation for whatever type due to the intestine, post-infectious gastroenteritis, and so maybe there's some infection that is kind of lingering around in the GI system that's causing some of these symptoms, and then bacterial overgrowth, and so if there is bacteria in there and it is just getting too out of hand, that can also cause these types of IBS to inflame as well. This is just a nice visual for you guys to see what IBS kind of looks like on the inside, so you can see that we have areas of spasm above and below that distended bowel. And so again, like, this doesn't really tell what subtype of that we're dealing with here, but it just does show that inflammation of the intestine itself, or the colon, and being able to see that the stricture areas above and below that can spasm due to that inflammation and the distension that's occurring. So like I had said previously, is that IBS is pretty broad, and so depending on what subtype of IBS that we're dealing with, their symptoms are going to be presenting a little bit different. And so some symptoms, or common IBS symptoms, are going to be belching, diarrhea, constipation, flatus, mucus in the stool for type D, abdominal pain in that left lower quadrant that increases after eating and is usually relieved when going to the bathroom. So again, there's really no definitive diagnostic test for IBS. It's all going to be manifestation and symptom based. There is one Rome diagnostic criteria functional instrument that is used to kind of give physicians a guideline for diagnosing that if they are having GI problems and are suspected of IBS based on their manifestations, we can use this criteria tool to determine and come to a diagnosis of this. So the diagnostic criteria looks like this. So recurrent abdominal pain for at least 1 day a week in the last 3 months, and have 2 of the following. So improvement with defecation, onset associated with change of frequency in stool, and onset associated with change in stool appearance. So it has to have abdominal pain at least for 1 day a week in the last 3 months, and then 2 of the 3 bullet points below. If that doesn't make sense, reach out to me or look up the Rome diagnostic criteria on your own, but it is pretty laid out for physicians to be able to diagnose this based on this instrument and those manifestations that a patient is presenting with. So the way that we treat IBS based on manifestations and symptom control. And so a lot of it is going to be dietary modification. So depending on the subtype, it's going to be a lot of trial and error. So knowing what, how the body responds to different types of foods, because everyone is going to be different. No IBS is going to look the same as somebody else's, because everybody's body is going to have triggers and respond differently to stress. And so depending on what what diet modifications need to occur based on the triggers and stress for that patient. But in general, we want to stay away from the FODMAPs is what we call them, and that's basically a bunch of different like types of sugars. And so we have the oligos, the dyes, the monosaccharides, and the polys. And basically the most common things that you'll find all of these types of sugars in is going to be apples, pears, cherries, and wheat. And so those are the big ones that researchers have found are going to be the most triggering for IBS and a broad type of all the IBSs. But again, it's really going to be patient specific. Other complementary and alternative therapies that can help is going to be yoga, massage, meditation, certain herbal remedies, chamomile tea, peppermint, fennel, and ginger. But again, we also don't want to be educating on those herbal remedies because they may not be FDA regulated, which is kind of your little safety alert on the side there. What I want you guys to know based on the pharmacology aspects is what subtype is it? So for example, the first one here is IBS type D, knowing that that one is the cause of diarrhea. And so what we'd want to give for pharm-wise would be an anti-diarrheal like loperamide, which is going to slow that bowel movement and enhance absorption. That's what I want you guys to know. So know each type of IBS that we're dealing with. So constipation, IBS type C, we would want to do selective type 2 chloride channel activators because that's going to increase the fluid secretion in the small intestine and increase motility, loosening up that stool so that they're not constipated anymore. That's what I want you guys to focus on. Okay, talking about complications and interventions. So this slide is going to be specifically talking about IBS type D, so that frequent diarrhea. A lot of times when people are needing to go to the bathroom multiple times an hour, they're not going to really want to be going out. And so whether that's missing school, missing class, missing work, whatever the case may be, they might try to socially isolate while they're trying to deal with their IBS flare-up at that time. And so getting them with support groups, because a lot of times they're going to social isolate even past that trigger or past that flare up, and it's going to impact their physical functioning. And so we would want to focus on their emotional state. Dealing with spasms, constipation, and diarrhea, we want to rule out other causes. And so if they are dealing with other things in conjunction with this, we want to know about those as well. Other two biggest things that I want you guys to know is that when we're going to the bathroom a lot, we are at risk for fluid volume deficit because of the diarrhea, and then hypokalemia because of the frequency and the losing the potassium through the diarrhea. And then when we don't have enough fluids in the body, we also are losing potassium in the cells that way as well. And so those are your two biggest complications that we also want to focus on. So if they are having a flare up, we're going to need to be focusing on giving them IV fluids, maybe some IV potassium, or maybe they need to be on a potassium pill if they're chronically hypokalemic, things like that. So knowing what we know about those complications, first thing that we're going to want to do as a nurse dealing with a patient with IBS-D, we want to put them on the vital signs monitor. If they are hypokalemic, we are definitely wanting them on the cardiac monitor because we know hypokalemia and dehydration are going to have cardiac effects. So we want to be making sure that we watch their vitals very closely. We want to be monitoring their INO, so if we're able to measure how much is going in versus how much is going out, that's really going to be beneficial to us as well. Electrolyte status, doing more than just hypokalemia monitoring, but also monitoring of all electrolytes. If they are having pain, we want to address that. If they have had diarrhea for over a week, they probably have lost a significant amount of weight, and so we're probably going to be doing daily weights. And then again, that psychosocial assessment. Education-wise, what can we educate on this? So avoiding those trigger foods, what has caused this exacerbation of symptoms? What can we do to prevent this from occurring again? Was there certain things that we have now identified are triggers, or was there stressful situations that were going on? We can encourage them to exercise, or maybe exercise was the trigger, and so maybe we need to tell them to dial back the exercise a little bit. And so really catering to the patient on this education pieces. Drinking enough water because of losing the amount of fluid through diarrhea. That's the biggest way that you lose fluid. They need to be drinking at least 6 to 8 glasses of water a day. What would it look like if this was successful? We'd want to see stable vital signs and weight, decrease in manifestations, and then they are understanding and adhering to their nutrition and activity recommendations. So referring back to that last slide, was exercise the trigger? Do they need to dial back? Or was it because they weren't exercising at all and now they need to dial up the exercise? Was there stress or foods that were triggering? So identifying if the patient understands and is going to make a change when they go to discharge home. Alrighty, moving on to chronic inflammatory bowel disease. And under this umbrella term, we're going to cover ulcerative colitis, Crohn's disease, and diverticulitis. Like I just mentioned, so IBD is kind of that umbrella term for all the types of IBD that fall under. So you have UC, CD, and diverticulitis. About 1.6 million Americans have some type of IBD, and actually Canada, interestingly enough, has the highest incidence in the world. I don't know where that comes from, but the more you know. Ulcerative colitis is going to be beginning in the rectum and proceeds to the cecum. Crohn's disease is going to be patchy involvement through all the layers of the bowel, occurs anywhere from the mouth to the anus, may skip over some areas, and diverticulitis is going to be inflammation and infection of the bowel mucosa. So every type of these is going to be dealing with some type of inflammatory process within the bowel. It just kind of depends on where and what's going on. All right, talking about ulcerative colitis. So UC and CD have very similar clinical features, but are two very different disease processes. And so UC is going to be defined as inflammation that is limited to only the colon and only the rectum. It involves the mucosal and submucosal linings and is found in continuous segments, which you're going to find in Crohn's is going to be different than that. So the way you can define UC is that it only is in the colon, it's only in the rectum, and it's continuous. The way that this looks moderatively exacerbated is going to be cramping, urgency with defecation, mild anemia, because we'll talk about blood in the stool a little bit later, fever, anorexia, weight loss, and moderate signs of systemic illness. Here is a list of severe exacerbation symptoms that occur with UC. So like I stated previously, frequent blood in the stools due to that inflammation in the rectum. We're going to see a lot of blood in the stools. Severe diarrhea, abdominal pain, significant anemia. We saw it moderatively. Now we're significantly seeing it because of that blood that's lost in the stools. Fever, weight loss, and then the increased ESR. Those are going to be your top ones that I want you guys to remember for significant severe exacerbations with UC. Now moving to Crohn's disease. So Crohn's is going to be the inflammatory process that's impacting any part of the GI tract from the mouth to the anus. So not just the rectum like we had talked about with UC. Now we have any part. So this could be the small intestine, the large intestine, anywhere in the GI from the mouth to the anus. It involves all layers of the bowel wall in a segmental fashion. So again, with the segments happening versus UC was continuous. Now Crohn's can be kind of spotty, hit or miss, maybe in the small intestine sometimes, maybe in the large intestine sometimes, but usually it's going to be in segments versus UC where we saw that continuous. What this looks like or symptom-wise, urgency to defecate, we've seen both of those in both of these disease processes. Crampy abdominal pain, similar to both of them. Diarrhea, fever, those are similar. Anorexia, weight loss, both similar. So really these symptoms are going to be pretty much the same for both of these, which is really why we need to go in and determine which process we're actually dealing with, where it's located, what it looks like. And so we'll talk about that in a minute here. You also may see with Crohn's disease, mouth ulcers, joint pain, liver disease, etc. So here is a picture with Crohn's laid on the left and ulcerative colitis laid on the right. So on the left you can see with CD is in the small intestine and UC is significantly in the large intestine. And so with Crohn's we can see these skin lesions within there. And then we can also see in this little picture those areas of red, so that segments that are occurring. So it's not a continuous process like we see on the right hand side when you see in that large intestine that it is just affecting that red portion all the way down. Not segmental, it's continuous. I do have another picture coming up here that'll show you kind of a live version of what these two look like side by side as well. Okay, so here's that picture that I was talking about. So we have CD on the left here and UC on the right. So we have that cobblestoning in the Crohn's, and then we have the pseudopolyps in ulcerative colitis. So how do we diagnose IBD? Diagnosing can be a little bit difficult because they do have trigger and flare uninflamed periods of time. And so we really want to try to diagnose when we actually are having a flare up. And so having them come in, which may be a little bit difficult with scheduling, but if we can, we definitely want to see it because it's going to be easiest to diagnose when we're actually having a flare. So the biggest thing, we use 3 different types of diagnostic tools. The first one is going to be colonoscopy. The second one is a flexible sigmoidoscopy, and the third one is barium enema, and that's just going to be looking at the in-depth of the disease involvement. So the colonoscopy, we can actually go in and we can see the difference between Crohn's and difference between UC and determine which one. And then the barium enema is going to be more in depth of which disease we have and the disease involvement. There are 5 different types of medications that we can use for management of IBD. I just want you guys to know the 5 types. You don't need to know examples or med types. I just want you to know which meds and what they are used for, so their mechanism of action. So for example, the first one, 5-aminoacylic acid, is an anti-inflammatory. Corticosteroids reduce inflammation. Immunosuppressants, that mechanism of action is actually unknown, but with immunosuppression it is known to help with IBD. Immunodilators suppress that immune system response, and the antidiarrheal symptoms management reduce the number of stools. So depending on what is going on symptom management, we can pick from these med management. I just want you to know these 5 types of different medications that we can use for IBD. We do have those corticosteroid considerations on the right hand side from there. So when we're using steroids, we definitely want to be watching for those side effects. These I do want you to know: the risk for infection, risk for osteoporosis, hypertension, and hyperglycemia. These nursing considerations for IBD hopefully are not new to you. We've seen these on previous slides, kind of that same thing where we're going to be fluid and electrolyte management. Like we've seen with previous diagnosis, the diarrhea, extreme loss of fluid, dealing with hypokalemia and other electrolyte imbalances, which alters the nutrition. So we want to be managing that, replacing fluid, replacing electrolytes as needed. Guidance of the terms of dietary modification. So again, educating on the smaller, more frequent meals, vitamin supplementation, especially B12 if they are taking the corticosteroids, emotional support, again, going to the bathroom, having diarrhea multiple times an hour. We need to be emotionally supporting these types of patients, teaching methods of reducing stress. So if a stress is triggering this to occur or a flare-up, we need to teach them how to better cope. Adjusting to remissions and exacerbations. It might be frustrating to be in remission and then have an exacerbation again, or maybe it's not a good time to be exacerbating again. And so just dealing with that, again, goes along with coping. Other thing, preparation for treatment plan. So if they do have chronic IBS or a spot that is inflamed chronically and is just not going away, we may need to do a colectomy to take out that part of the intestine to get rid of it and help them improve their quality of life, essentially. Alrighty, complications of IBD. A couple of the big ones that I just want to touch on. So perineal abscesses, strictures, or fistulas, CD or UC. Probably going to be more common with CD. Malabsorption, especially with Crohn's disease. Anemia from hemorrhage requiring blood transfusion, CD or UC, probably going to be more of that UC because of those frequent bloody stools. We're going to need to go in and replace the blood. Other complications, joint swelling, pain, osteoporosis, kidney stones, eye inflammation, mouth sores, skin lesions. If they are having inflammatory flare-ups, may experience fever, anorexia, malaise. So another thing that we are worried about with IBD is altered nutrition. So when the GI tract is inflamed in any sort of way, the GI tract is not going to be able to absorb nutrients like it was supposed to. And so one thing that we can do to provide nutrition is do TPN. TPN consists of fats, proteins, carbohydrates, some trace elements like zinc, copper, iron, and then sometimes we can actually even combine medications in with the TPN if needed so that we don't need to use another line. Sometimes they are compatible, so common medications that you might see combined with the TPN is PPIs, H2 blockers, insulin, or heparin. We're never going to abruptly stop TPN because we'll talk about on the next slide how blood glucose levels and the titration for blood glucose in TPN and how we do not want it to run out or stop because of the blood glucose that's in it. So TPN is going to be going in through a central line, and so some different nursing considerations with central lines are going to be different from peripheral lines, and so we'll talk about these here. But when we're giving TPN, we want to be monitoring vitals and labs frequently, and so daily we're going to be doing BMPs, CBCs, we're going to watch liver and renal labs, we're going to be monitoring the blood glucose. So again, there is a certain set glucose concentration in the TPN bag, and so if we ever run out of the TPN, they're no longer getting that glucose concentration from the TPN bag, and so we need to be keeping a 10% dextrose bag at the bedside in case we do run out and it hasn't been mixed up yet from the pharmacy. Biggest considerations with central lines, and so we need to prevent infection because it is a direct correlation to our heart. That's where that line leads, and so prevent infection is going to be a really bad deal if that does happen. And so we need to prevent infection, so maintaining sterility, cleaning the hub, following dressing change guidelines, sterility for dressing change guidelines, both central lines and PICS. Reducing air embolism, so with preventing air getting into the tube, again, it is a direct line to the heart, and so any air is going to be an embolus leading right into the heart, and that could lead to death in the patient. Also fluid overload, so when we're having central lines on the pump, we just want to be careful in maintaining the correct rates. So if you need another nurse to sign off with you or verify your rates, making sure that you are at the correct rate that's ordered to avoid fluid overload. The last IBS component that we are going to talk about is diverticulitis. Diverticulitis is inflammation and infection of the bowel mucosa. I have a picture on the next slide which will give you a good idea of what this looks like. Usually going to be the most common in older adults and men. The way that this manifests or signs and symptoms is going to be an acute onset of abdominal pain in the lower left quadrant, nausea, vomiting, fever, chills, tachycardia. And so with inflammation and infection, you guys can probably guess that these manifestations are going to resemble those inflammatory and infection markers. So how we can diagnose this is through those lab values. We're going to look at their history. We can do the ESR, which is those inflammatory markers, and then also a white blood cell count if we are looking for infection that will be elevated. We will do a CT scan to confirm. That's kind of our gold standard for diagnosing diverticulitis. And then one big thing to note is that what we are not going to do is a barium enema. So we really need to determine what signs and symptoms the patient is presenting with, because UC and CD, we do want to do a barium enema. But with diverticulitis, it's contraindicated because we don't want to get in and perforate those diverticulitis polyps. All right, so this is that picture that I was talking about of the diverticulitis. So that zoomed in portion of the colon on there here, you see that top where we have diverticula, and that is what the outpouching, those little polyps are called. When they're inflamed or infected, that's what we call diverticulitis. So we can have diverticula, but if they're not inflamed or infected, it doesn't mean anything, and the patient may not be symptomatic. And so they might be living with this currently, and we might not even know it because they're not inflamed or infected. Then if we have diverticulosis, that is non-inflamed diverticula. And so that's like the plural version of diverticula. So diverticula is each individual outpouching. Diverticulosis is what we call the cluster of those non-inflamed diverticula. And then once they become inflamed and infected, then that's when we get diverticulitis. So what we are going to do to manage diverticulitis is give PO antimicrobials because it is an inflammatory and an infection type thing. We're going to want to do oral antibiotics. So Cipro, Flagyl, Bactrim are going to be your three most common. If it's really complicated diverticulitis, we are going to focus on symptom management as well. So they're probably not going to be able to eat without some type of pain. And so they may need to be NPO or have an NG tube and have IV fluids until they're able to tolerate food and fluids again. When they can have food and fluids, we definitely want to start with clear fluids and low fiber until the symptoms subside or get better. A lot of times we do want to avoid foods that block the diverticulum, so seeds, popcorn, nuts can get stuck on those diverticula and make them become inflamed or infected, and so we need to avoid those types of foods that can get caught on those diverticula. And also just limit foods that irritate the bowel, which we have talked about on previous slides as well. The biggest, baddest thing that we don't want to happen is we want to be able to catch this diverticulitis early, because when they're inflamed and infected, they can only get inflamed to a certain amount of time. And those diverticula, when they're inflamed and infected, it's because there's bacteria in there. And when they get so inflamed and infected, they will rupture. And so when they rupture, then that bacteria is free in the body and causes a lot of problems, because it's free bacteria causing infection, not just in the colon, but also in a lot of different places. And so when rupture happens, we could be dealing with peritonitis, bowel obstruction, uncontrolled bleeding, and abscess. And so maybe even need to go in and resect the colon, which then the patient may end up with a colostomy, worst case scenario. All right, this brings us to part 4, where we are going to discuss lower GI disorders. That includes celiac disease and colorectal cancer, and that will be a wrap of our GI stuff. Alrighty, so beginning with celiac disease, also known as SPRU or gluten-sensitive enteropathy. So this is where we have a permanent intestinal intolerance to dietary wheat or gluten that are related to proteins that produce mucosal lesions within the GI system. So we also can be sensitive to gluten products. Females are going to be more commonly celiac disease patients over males, more common in Caucasians, and then also does have a genetic autoimmune disorder that damages the small intestine. So when someone is experiencing celiac disease, they're probably going to experience quite a bit of weight loss and general malnutrition from the damage that occurs in the small intestine. Because of the intolerance to these types of foods, we develop a chronic diarrhea or stayuria, which is like a fatty stool, usually going to be like a pale, watery, and insidious onset. Other symptoms are abdominal distension, muscle wasting, anorexia, and irritability. How we can define celiac disease, or the things that we want to stay away from, is called BROW. So we want to stay away from foods that include barley, rye, oats, and wheat. 3 different ways that we can actually diagnose besides symptomatically. We can look at genetic testing, we can do biopsy, and we can also look at antibodies that are against the gliadin or the anti-TTG anti-tissue transglutaminase antibody. And that's going to be like the test that determines if there is any of these antibodies within the system that is actually causing this lining of the small intestine to be damaged because of the products from brow that the person would be ingesting. Another tool for you guys to be able to remember what management of celiac disease looks like. It actually stands for celiac. So the C is consulting a dietitian to make those diet modifications. E is going to be educating about the disease to the patient and making those modifications and what that's going to look like, signs and symptoms to watch out for, or triggers. Lifelong adherence is L, so we're gonna lifelong be non-gluten products or have a gluten-free diet, be free of any of those brow products, because it's not something that is going to go away. It is genetic and it's always going to be there, and so this is a lifestyle modification. It's not really something that is going to come and go. It's going to always be there and be triggered by those foods. I is identify and treat malabsorption and malnutrition. So if we are early on and we're diagnosing and they have lost weight or are malnutrized because of these foods that they've eaten previously, we need to get them back to that place where they have those nutrient dense foods, and again adhering to the gluten-free diet products. A is for access support groups. Celiac Foundation is a good resource for any of these patients, but there are plenty of support groups out there, so many resources in the community. C stands for continued management via interdisciplinary team, and so nutrition is going to be involved, maybe case management's involved. The RN is always going to be a good resource. You guys are going to be able to educate constantly anytime we see these types of patients, so everybody is going to be involved. Last thing I want to note, if we are in a period of inflammation, we really want to stay away from high fiber foods like nuts, raw fruits and vegetables, because when we are exposed to these, we deal with diarrhea, and when we have high fiber foods, then they're at more risk for having constant diarrhea, because fiber obviously makes your intestines work a little bit faster, and then we deal with more diarrhea. So we want to stay away from those foods if we are in a period of inflammation. All right, a little bit more patient education that we can give to our patients with celiac disease is we want to make sure that they're using the dishwasher to be sure that we're getting off all of those products. We don't want to be ingesting those things. Gluten-free diet adherence, so we talked about this, adhering for a lifetime. It's not something that's going to go away, so we need to be adhering to the gluten-free diet always. We want to make sure that they're reading food labels. Sometimes the labels aren't always apparent and revealing what products are in what, so they do try to hide it. It's really important that you read that fine print on the back. Goes along with the gluten-free products, reading those food labels. And then again, there's plenty of gluten-free resources out there. Find Me Gluten Free is a good resource as well. All right, going into talking about colorectal cancer. So this is a third most common form of cancer and actually the second leading cause of death within the United States. In 2024 alone, there was actually 106,000 new cases of colon cancer and 46,000 new cases of rectal cancer in the United States alone. So that is a significant amount of people. Cecal cancers are also on the rise. Anything that has to do with the colon, pretty bad. We talked about this previously about how a lot of times those symptoms are masked until it's a little bit too late. So we'll talk about that a little bit here. Risk factors wise, family history. If they've had IBS for 10 years or more, they're at an increased risk for developing colorectal cancer. Physical activity, obesity, type 2 diabetes, and then a diet high in processed meat, low in fiber, and low in fruits and vegetables. A little bit of pathophys for you guys. So most of the colorectal cancer cells are going to be adenocarcinomas, and those are going to be the most common to metastasize to organs in the lymphatic system or the bloodstream. This is a really bad deal. Like I said, once we don't really notice until it's too late. Seeding may also occur with tumor removal, and so if we do think we can resect the tumor, actually it is a risk going in and taking out the tumor and having fragments be lost within that process and actually go into seed other metastasis in other places in the body. So it is pretty risky to even go in and try to resect the tumors if possible. Clinical manifestations of colorectal cancer, unexplained weight loss and fatigue are going to be the often earliest signs, but again, like those signs are not very apparent. A lot of times we lose weight and feel fatigued for a lot of other reasons, and so colorectal cancer, when you feel fatigued and are experiencing weight loss, it probably is not going to be the first thing on your list. So those are going to be the two earliest signs. Pain, change in bowel habits, stool characteristics, and presence of bright red blood in the stool, and anemia because of the stool because of the bright red blood in the stool. Again, once we get to having pain and having bright red stools and that anemia because of it, it's probably going to be a little bit too late. This is a nice visual for you guys to take a look at about where tumors could possibly be lying in the colon. So depending on where the tumor is, different signs and symptoms are going to present. So starting on the left-hand side, the ascending colon, going to experience abdominal pain, cramping, changing bowel habits, anemia, and fatigued. And I'm not going to read all of these to you guys, but again, just a good visual for you to be able to see what clinical manifestations are going to be associated from where the tumor is in the colon. All right, so what are our diagnostic tests? Colonoscopy is going to be the gold standard for screening for colorectal cancer. Screening starts at age 45 if they are at average risk. Cologuard, DRE, fecal occult blood tests can be done. CEAs, we can look at blood tests, CBC, and then we also have the TNM staging, the tumor node metastasis staging. The prognosis worsens at the size and the depth of the tumor and how many lymph nodes are going to be involved and how many actually have metastasized. So if you guys are interested in taking a look at that, it's on table 58.5 in your test to show the classification and staging system. What I really want you to know is that the gold standard is the colonoscopy starting at age 45 if they're at average risk. All right, we did talk about both of these previously, so I'm not going to talk too in depth on these, but we can do chemotherapy and we can do radiation therapy. Biggest thing I want to note with like the radiation therapy is that usually we start with the radiation to try if we can shrink that tumor at all and then go in and resect it, but a lot of times it's going to be too late and the risk of those fragments getting left behind for reseeding is pretty high, and so it really depends on where the tumor is and the metastasis, the staging, classification, things like that. This is a pretty important slide for you guys. So surgical management, we can do what's called a colectomy, and that's removing part or all of the colon. A hemicolectomy is half or less of the colon being removed. And then we can also do an abdominal perineal resection, and that's when we actually remove the colon and the rectum altogether. The anus is closed, and then they will have a permanent ileostomy for the rest of their life. So I really do want you guys to know these terms because they're important. Surgical complications from any of these procedures, blood loss. Anytime we go in surgically, we're always going to be monitoring for blood loss, infection at that site, anastomosis leak, and incisional dehiscence. Pre-op care for any of these surgical interventions, we're always going to get a baseline vital signs, a baseline CBC, so we have something to compare it to a post-op. We're always going to do a bowel prep because we want to minimize the bacterial growth and prevent contamination of feces during the surgery, so they always do a bowel prep with like Go Lightly is a good example. We also will always do an antibiotic prior to incision for that prophylactic antibiotic. Establish a therapeutic communication, building trust with your patient, always so important pre-op. They want to make sure that they trust you because it's a procedure, it's a big deal. They might be fully sedated. So just making sure that they know who's in the room, building trust with them is really important. Ensure your surgical consent is signed before any sedation or narcotics. This is a big one. And then also make any consults if an ostomy is anticipated because there's going to be a lot of education that goes along with an ostomy. Alrighty, this is a really nice visual for you guys to be able to see the different locations of stomas. So depending on the portion of the colon that has to be removed is where the stoma is going to go. That's kind of why if you guys have ever seen in practice, the stomas aren't always in the same place. They can be in different places depending on how much of the colon that they actually had to remove. On the bottom you can see actually the difference between the colonoscopy and the ileostomy as well. So the ileostomy is because the stoma is on the small intestine and not actually on the colon, which is where we get colostomy versus ileostomy. This is another really nice visual for you guys to be able to see what types of stool are going to be formed at different colostomy sites. So obviously as food travels down, different types of absorption and breakdown in the GI process all the way down until it gets to our anus. So at different points where the colostomy is, obviously is at a different point where the stool has formed, and so that's where we get the different types of stool at different locations. Alrighty, a couple post-op nursing diagnoses. So our first one is acute pain associated with the surgical incision. So we're always going to be treating the pain when we have a post-op patient, no matter what, but especially for one who just has a new ileostomy or a new colostomy, we definitely want to be treating pain. Second one is potential for infection associated with the interruption of primary defenses of the skin and indwelling tubes and drains. So depending on what we actually did, being that we put in those colostomy, we want to definitely be watching because we have interrupted that skin process wherever the colostomy is located, and so we'll be looking for potentials for infection. Third one is going to be risk for imbalanced fluid volume associated with response to abdominal surgery, blood loss, manipulation to bowel tissue causing fluid and electrolytes to shift. So again, with surgery, we always are going to be monitoring hemoglobin pre-op and post-op, and then because of the bowel tissue being manipulated and moved around, absorption is going to take a little bit to come back, and so we want to be watching what fluid and electrolyte statuses are. The fourth one is knowledge deficit associated with post-op care. So we're going to be educating on post-op care. This kind of goes along with point number 5 with the disturbed body image associated with a new ostomy. So we're going to be giving knowledge and education post-op for ostomy cares, what that looks like, which we'll talk about on the next slide here. I was actually wrong. The post-op ostomy education stuff is actually on the next slide, but this slide is going to be talking about post-op nursing management. And so biggest things is that we're going to be doing vital signs at least every 4 hours, if not more than that. Again, with the blood loss, we're going to be watching the hemoglobin pre-op and post-op to see how much blood loss was during surgery. We're going to be monitoring their LOC, so anytime that they're waking up from sedation, we want to assess the ability for them to awake and arise. We are going to be addressing pain with a new ostomy and that breakage of the skin, newly uncomfortable, different types of incisional pain we're going to be addressing. We are going to be assessing for bowel sounds, and usually with new ostomies and any type we do a colon surgery, bowel sounds are going to be absent between 1 to 3 days post surgery, and that is normal, but hoping that it returns sooner rather than later, maybe closer to that 1-2 day mark. But if it is 3 to 4, then we're just going to be monitoring even more. Nausea, vomiting, they're probably going to have an NG until their bowel function returns, just so that we know that they are tolerating and getting the nutrition that they need. We're going to be monitoring eyes and nose, and then we're also going to be doing incident spirometry. We want to get them up and walking, early ambulation to make sure that they don't develop those VTEs. And then we are going to be doing stoma site and stoma care, so we can have the wound nurse consulted if we need to, but also we just want to be aware as the RN too what type of care so that we can manage it ourselves, but then also be able to educate the patient before they go home. Drainage management, they're going to have a JP drain in place for about 3 to 5 days. We always want to note the amount, color, and odor of the drainage. Usually drainage is always going to be that serosanguinous drainage. Ostomy drainage, we also want to note the type, amount, appearance, and consistency. Hopefully those things go along with kind of that visual that I had previously listed on what the stool should look like, but sometimes with new ostomies it does take a couple days for that stool to look the way that it's supposed to. Abdominal dressing and incision, obviously monitoring for any type of drainage, bleeding, saturation on the dressing, signs of infection, which goes with that perianal incision care as well. Alrighty, then last but not least, now we will talk about the ostomy patient teaching. So with new ostomies, we definitely want to be educating on limiting raw vegetables because that causes the high odor and gas. I don't know if any of you guys have ever dealt with colostomies or ileostomies, but they are known and have that stigma of being really, really smelly because patients don't necessarily know what causes odors and gas to occur. And so we want to avoid foods and triggers for that patient because we don't want any nasty odors or gas in excess because it actually will cause your bag to explode if you're not watching it properly. Output should start between 2 to 3 days, so making sure that they know what to be watching for. The stoma site itself should always be pink and red and moist. If it's anything other than that, they probably should come in and be seen. Purple, blue, or dusky color indicates ischemia. We really, really want to see them if that happens. Black indicates necrosis. Again, they need to be seen if either of these two complications of their stoma site is occurring. We want to monitor the skin around the stoma for breakdown. Usually with new stomas, there's going to be a lot more breakdown because of the adherence of the bag itself around the skin around the stoma. And so usually there's going to be some redness, some breakdown. And so if we can avoid that, if at all possible, we just need to keep monitoring it. Might have edema or a small amount of blood around the stoma itself for the first couple of days. That's normal post-op to have that edema or that blood around it, but after a week or so it should never come back like that. This little picture up in the right upper corner or the right middle shows the when to empty the ostomy bag. So this is a nice visual that you could print out to show your patient, showing that at about a third full we should be emptying the bag. That's the ideal time. When you get about half full, you're still okay, but we really need to empty it at that point or find a place to empty it. Once we hit over halfway, we're living on the edge, and 3/4 of the way full, we're looking for trouble. We definitely don't want any backup into the colon again or in the small intestine for ileostomies. So really educating on when is a good time for patients to empty it. Again, it's going to be a lifestyle change for them. And so really focusing on that education and that emotional state as well. All right, this wraps up our final GI slide. So if you guys have any questions on any of the GI stuff, let me know. Otherwise, I will be back for the male reproductive slide soon.